Good morning, everyone. I am Dr. Anisha, practicing periodontist and implantologist. I have completed my post-graduation from Royal Dental College, Palakkad. Today, it is my privilege to present Section 3 of our reading club as a part of Misch Contemporary Implant Dentistry held in connection with the International Implant Summit 2026. We now move on to Chapter 13, Dental Implant Infections. Causes and risk of dental implant infection. Infection is one of the most important causes of early dental implant failure and may be an indication of a much more critical result than if the same complications occur later because of disturbance of the primary bone healing process. Infection before the implant placement. Active infection site. Immediate dental implant placement and function after tooth extraction has become a widely accepted practice in contemporary dental implantology. Whether completed with or without immediate function, comparative clinical studies have found that implant survival rates after immediate dental implant placement are similar to rates seen with delayed dental implant placement. Clinical case series have shown favorable results in immediate dental implant placement into chronically infected sites. High implant survival rates have been reported even when implants were placed immediately in infected extraction sockets and provisionalized within 36 hours. Early or immediate loading of dental implants placed into periodontally or endodontically infected sites produce no statistically significant difference in failure rates between chronically infected or non-infected sites. Periodontal disease. Periodontal disease is a chronic infectious and inflammatory response to pathologic changes in periodontium to an anaerobic microenvironment. These changes generally result in an imbalance and aggregation of deleterious microorganisms that may lead to the development of perimucositis, periimplantitis, and bone loss. Comparisons of clinical, microbiologic, and host response characteristics between healthy dental implants and healthy teeth and between infected implants and periodontally diseased teeth have found to be similar, respectively, with subjects at risk for periodontal disease also at risk for periimplantitis. Immediate dental implant placement into fresh extraction sockets with periodontal infection has been evaluated at single and multiple tooth reconstruction and shown to be a valid option with predictable results. Single dental implants placed into periodontally infected extraction sites have shown at 12-month follow-up to be asymptomatic with no signs of infection or bleeding on probing, no decrease in radiographic bone implant contact, and no loss of clinical attachment level or keratinized mucosa width at the mid-buccal location per implant. Immediate loading in periodontal disease. Immediately placed and immediately loaded dental implants have been shown to be predictable and successful. Immediate implant loading of complete mandibular implant retained prosthesis may be a viable treatment option for edentulous individuals with a history of chronic periodontal infection. Dental implants immediately placed in chronically infected sockets and immediately loaded with a fixed, full arch maxillary and mandibular prosthesis have been shown to have excellent short-term success and a 3-year cumulative surgical and prosthetic survival rates. Peri-implant disease, perimucositis and periimplantitis. Peri-implant mucositis is characterized by biofilm-induced inflammation localized on the soft peri-implant mucosa but with no evidence of destruction of the supporting bone. Periimplantitis is an irreversible inflammatory reaction in the soft and hard peri-implant tissues. Plaque accumulation around dental implants has been shown to result in the development of peri-implant inflammation. Contributing factors for the development of peri-implantitis include periodontal disease, smoking, excess cement, and lack of supportive therapy. Proceeding to the next chapter of the session, Pharmacology in Implant Dentistry. Because of the increase in demand and use of dental implants in dentistry today, a thorough understanding of the indications and protocol for the use of pharmacologic agents in implant dentistry is essential for the implant clinician. The morbidity of implant-related complication may on occasion be significant. Therefore, ideal medication selection and sufficient dosage levels of medications are preoperatively and postoperatively indicated. Antimicrobials. An important complication to prevent after implant surgery is infection. Infectious episodes may lead to a multitude of problems including pain, swelling, loss of bone, and possible failure of the implant. Because of the risk for morbidity resulting from infections, antimicrobial therapy is an essential component of the surgical protocol. Antibiotics. Antibiotic therapy in implant dentistry may be classified as either prophylactic or therapeutic. Prophylactic antibiotics. The main goal of the use of prophylactic antibiotics is to prevent infection during the initial healing period from the surgical wound site, thus decreasing the risk for infectious complications of the soft and hard tissues. A landmark study by Berg defined the scientific basis for the perioperative use of antibiotics to prevent surgical wound infection. From this work, several accepted principles have been established in the perioperative use of prophylactic antibiotics. Principle 1. The procedure should have a significant risk for an incidence of post-operative infection. Principle 2. The appropriate antibiotic for the surgical procedure must be selected. Principle 3. An appropriate tissue concentration of the antibiotic must be present at the time of surgery. And principle 4, use of the shortest effective antibiotic. Complications of antibiotic prophylaxis. Incidence of significant complications with the use of prophylactic antibiotics are minimal. However, a small percentage can be life-threatening. The risk associated with antibiotics include gastrointestinal tract complications, colonization of resistant or fungal strain, cross-reaction with other medications, and allergic reactions. Prophylactic antibiotics in oral implantology. The antibiotic chosen for prophylaxis should encompass the bacteria most known to be responsible for the type of infection related to the surgical procedure. Therefore, the following antibiotics are suggested against pathogen known to cause post-operative surgical wound infection in bone grafting or implant surgery. Amoxicillin is the usual drug of choice. However, if the patient is allergic to amoxicillin, use cephalexin, non-anaphylactic allergy to penicillin, or clindamycin, anaphylactic allergy to penicillin. For sinus involvement procedure, the following antibiotics are suggested: Augmentin or Ceftin if history of recent use of antibiotics within 4 weeks, or doxycycline. Therapeutic use of antibiotics, post-operative infections. Acute post-operative infections have been shown to most commonly occur on the 3rd to 4th day after surgery. Local signs of infection are pain, inflammation, bleeding, and exudate at the site of surgery. Systemic signs include fever, headache, nausea, muscle aches, vomiting, and weakness. Therapeutic antibiotics in implant dentistry. The recommended treatment for intraoral infections associated with grafting or implant therapy includes: first, surgical drainage; second, Systemic antibiotics, which include amoxicillin 500 mg, 2 immediately, then 1 tablet 3 times daily for 1 week. Or if penicillin allergy exists, clindamycin 300 mg, 2 immediately, then 1 tablet 3 times daily for 1 week. If no improvement is seen after 4 days, a culture and sensitivity test may be obtained to select the antibiotic that is most effective against the responsible organisms. Third, 0.12% chlorhexidine gluconate rinse. Miscellaneous citric acid. Citric acid has been reported in the literature for the detoxification of exposed implant surfaces resulting from bone loss. Citric acid is stated to remove the smear layer, lipopolysaccharides, and exposure of collagen fibrils. The detoxification results in the improvement of blood clot formation with a greater fibrin retention fibrin. Management of post-operative inflammation. The management of post-surgical swelling is crucial to pain management, control of edema, and incidence of post-operative infection. In most dental implant surgeries, tissue is traumatized, which results in some degree of an inflammatory reaction. By controlling the extent of inflammation associated with surgical procedures, edema, trismus, pain, and infection may be reduced. The mediators of inflammatory process include cyclooxygenase and prostaglandins, which play a significant role in the development of post-operative inflammation and pain. For post-operative treatment, medications such as ibuprofen, non-steroidal anti-inflammatory drugs, and glucocorticosteroids are used, which play an integral part in counteracting the negative effects of this cascade. Cryotherapy, an additional therapeutic regimen to help reduce the amount and duration of post-operative inflammation, is the application of cold dressings. The application of cold dressings is believed to cause vasoconstriction of the capillary vessels, thus reducing the flow of blood and lymph in this region, resulting in less inflammation. Post-surgical pain management. The goal for pain control in oral implantology is to obtain analgesic levels before the cessation of local anesthesia and a well-administered post-operative analgesic regimen for patient comfort. Protocols post-operative pain. In implant dentistry, different classifications and mechanisms of pain suppression may be used. The most effective technique to decrease pain is a combination of preemptive analgesia and a multimodal pain management protocol. Prophylactic analgesics include preemptive analgesia, and post-operative analgesics include non-opioid analgesics, opioid analgesics, and adjuvants. Preemptive analgesia. Preemptive analgesia is defined as the introduction of an analgesic regimen before the onset of noxious stimuli. In relation to dental implant surgery, it is advantageous to have adequate analgesic blood levels present before the initiation of surgery. Combination analgesic therapy for post-operative pain. A pain management strategy using multiple analgesics with different mechanism of action is termed combination analgesic therapy. The goal of combining different type of analgesics is to increase the analgesic effect while decreasing possible side effects. When multiple drugs are used in combination, synergistic and additive effects allow for the use of lower doses of each individual drug. Control of post-operative surgical pain. The goal of post-surgical pain management is to optimize the patient comfort through pharmacologic and behavioral strategies. The World Health Organization formulated an analgesic ladder for the treatment of pain management. The following protocol describes 3 steps in the treatment of acute pain. The first step is to maximize the use of NSAIDs, acetaminophen, ibuprofen for mild to moderate pain. When moderate pain is expected or persists, an opioid, hydrocodone or codeine should be added to the NSAID. The fixed dose of opioids with the NSAIDs provide additive analgesia. Adjuvant medications such as glucocorticoids and cryotherapy are often suggested. Moderate to severe pain that is expected or persists should be treated by increasing the dosage of the opioid. Adjuvant medications such as glucocorticoids and cryotherapy are often suggested. Pain control protocol. Preoperative evaluation, which includes a thorough evaluation that includes a comprehensive medical and dental history. Then assess and check the prescription monitoring program for the past and current use of the earlier drug categories. Development of a pain control protocol. After obtaining this information, the following prescribing protocol may be followed. Step 1. Preemptive analgesics. The use of ibuprofen 400 mg, acetaminophen 1000 mg or celecoxib 200 mg should be taken 1 hour before the procedure. Step 2. Non-opioid analgesics should be used as the first line of pain control. Step 3. If an opioid is warranted, the following protocols should be adhered to. The lowest effective opioid dose of immediate release opioids should be prescribed. Quantity should be proportional to the expected duration of pain. Usually, this will cover 3 days, and a quantity exceeding 7 days is rare. Obtain medical clearance before prescribing opioid medications to any patient with a history of chronic use. Local anesthetics. Local anesthetics are an integral component of all dental implant surgical procedures. They are necessary to perform surgery without pain and are effective for decreasing onset and duration of pain. The dental surgeon must have significant knowledge of the pharmacokinetics of the different local anesthetics used in implant dentistry. The most commonly used dental anesthetics are amides, which are known for their low toxicity and relative lack of allergenicity. Post-surgical anesthetic use. To keep the patient as comfortable as possible, the use of long-acting anesthetics is highly recommended both in the beginning and at the end of the procedure. By administering a long-acting anesthetic at the end, the patient will remain pain-free longer and will have a decrease in the initiation of noxious stimuli. However, care must be given to the number and the amount of local anesthetic to avoid overdosage. The most common long-acting amide anesthetic is bupivacaine. Sedative agents. The use of conscious sedation is a valuable adjunct to dental implant procedures. The American Dental Association defines conscious sedation as a minimally depressed level of consciousness that retains the patient's ability to independently and continuously maintain an airway and respond appropriately to physical stimulation or verbal command, and that is produced by a pharmacologic or non-pharmacologic method or combination thereof. The most commonly used sedative agents include benzodiazepines, which include diazepam, midazolam, triazolam. Additional sedative anxiolytics include fentanyl, propofol. Reversal agents include flumazenil. It is a benzodiazepine antagonist used as a reversal agent for the treatment of benzodiazepine overdose. Comprehensive pharmacologic protocol. Because of the many variables like local, systemic, surgical that need to be considered with the use of pharmacologic agents in implant dentistry, a protocol has been developed to standardize the prophylactic use of these agents. A 5-category classification is proposed based on the patient's ASA status and the procedure type. First, patient selection. Patients are evaluated according to their ASA status. ASA 1 normal, healthy patient. ASA 2 mild systemic disease. ASA 3 severe systemic disease. And ASA 4 patient with severe systemic disease that is a threat to life. Second, procedures. The specific procedures are categorized into the protocol according to the extent, invasiveness, surgery duration, and expected bleeding. Third, antimicrobials. The type of antibiotic is selected that is most specific to combat the type of bacteria present in the surgical area. The duration of antibiotic use is dictated by the patient's health status and invasiveness of the procedure. The first line antibiotic is amoxicillin for type 1 to 4 categories and augmentin for type 5 category. Second line antibiotics include clindamycin type 1 to 4 and ceftin or doxycycline for type 5. The use of chlorhexidine is recommended with all implant procedure before and after surgery. Fourth, glucocorticoid. Dexamethasone 4 mg is recommended for type 2 to 5 surgeries with an increased dose and duration in relation to the extent and invasiveness of surgery. And fifth one, analgesic. Ibuprofen is the ideal preemptive analgesic to be used in all surgeries. Alternatives to ibuprofen would include acetaminophen. The procedures in category 1 include single implants with minimal reflection. Category 2 include traumatic extraction with pathology, socket grafting, single tooth implants with extensive reflection, multiple implants with minimal tissue reflection, subventral 1 sinus procedure, immediate implants without pathology. Category 3 include single implants with bone grafting and excessive tissue reflection, multiple implants with extensive reflection, bone grafting. Category 4 includes any category 3 procedure with surgical or patient factor, immediate implants with pathology, autogenous onlay grafting. And category 5 includes all subventral 2, subventral 3, subventral 4 sinus procedure. This brings us to the conclusion of section 3 of our reading club. Thank you.